It is well recognized that patients with lower extremity PAD have a heightened risk of major adverse cardiovascular events. Those PAD patients who require revascularization are at a very high risk for limb outcomes and MACE outcomes, early and long-term. Of note, acute limb ischemia is the STEMI equivalent of the limb. VOYAGER PAD included PAD patients undergoing lower extremity revascularization for ischemic symptoms. Over 6,500 patients were all on low-dose aspirin or clopidogrel at the investigator's discretion. Then randomized to rivaroxaban 2.5 mg twice daily versus placebo. Median follow-up was 28 months, and ascertainment of outcomes was known in 99% of patients. Patients were over the age of 50 and had to have PAD including symptoms with imaging evidence and an abnormal ABI. Major exclusion criteria included asymptomatic disease, a recent acute coronary syndrome, major tissue loss, need for other anticoagulation or antiplatelet therapy, or at high risk of bleeding. The baseline characteristics are as follows. Average age was 67 years, 26% were women, 40% diabetic, and about a third were active smokers. 30% had CAD, with 11% having had a previous MI. Majority of patients were on a statin or an ACE inhibitor, and 50% of the patients were on clopidogrel. About a quarter of the patients got in due to critical limb ischemia, 3/4 due to claudication. 35% had a surgical revascularization, with 65% having had endovascular repair or a hybrid. Median time from procedure to randomization was 5 days. The primary endpoint was acute limb ischemia, major amputation, myocardial infarction, ischemic stroke, and cardiovascular death. You can see a high rate of events up to 20% in the placebo arm. In the rivaroxaban group, the curves separate early, and there was a significant 15% relative risk reduction. At 3 years, there was a 2.6 absolute risk reduction, representing an NNT of 39. Overall, there was consistent reduction in all the components of the 5-point MACE. Acute limb ischemia was the most frequent outcome in the placebo arm, with a robust reduction in the rivaroxaban group. There was no difference in the cardiovascular death group. There was consistency across all major subgroups, including elderly patients and those who presented with critical limb ischemia. There was consistent benefit among patients who were treated surgically versus an endovascular intervention. There were higher rates of bleeding with rivaroxaban, with an absolute risk increase of only 0.27% per year. There was no difference in intracranial hemorrhage or fatal bleeding. Of note, the efficacy was maintained regardless of background use of clopidogrel, with higher bleeding rates for those on triple therapy. In summary, rivaroxaban 2.5 mg daily with aspirin compared to aspirin alone significantly reduced major outcomes early and continued over the course of the trial, with consistent benefits across major subgroups.